Hello friends, today we are going to discuss about the catheter related bloodstream infection. So catheter related bloodstream infection is the clinical definition of bloodstream infection where infection is attributed to an intravascular catheter by means of quantitative culture of catheter teeth or by differential time to positivity between catheter and peripheral venipuncture spacing. The definition is used for treatment as it precisely identifies the line-related bloodstream infection. Now, the second terminology is CRBSI. It is an infection where eligible bloodstream infection organism is identified and eligible central line in patient is present within 48-hour period before development of bloodstream infection that is not related to the infection at another site. So common etiological agent of CRBSI. This includes gram-positive organism like Staphylococcus aureus, Coagulus negative Staphylococci including Staphylococcus epidermidis, Enterococcus species, Corynebacterium species, especially Corynebacterium jaicum. Then gram-negative includes Enterobacter species, Acinetobacter baumannii, Klebsiella species. Then Pseudomonas aeruginosa, Citrobacterial friendly, Serratia marcescens, Burkholderia capacia complex, Stenotrophoma species. Yeast, which includes Candida albicans, Candida tropicalis, Candida parapsilosis, and Malassezia furfur. Now, pathogenesis. There are four routes of for catheter contamination. First, the skin pathogen at the insertion site can enter cutaneous catheter tract and migrate down the external surface of catheter towards the tube. This most commonly happens within the first 7 days after catheter placement and is thought to occur at the time of insertion. Insertion site contamination can also happen when skin microorganism density increase underneath the catheter dressing over time and if the area is not decontaminated frequently. Second, intraluminal contamination can happen when catheter hub is manipulated. Pathogen gain access into intraluminal surface of the device where they adhere and become incorporated into biofilm, which allows for sustained infection and hematogenous dissemination. This contamination typically happens more than 7 days after catheter insertion and is related to the care and maintenance of the catheter, as well as the number of times the catheter is manipulated and accessed. Third, less commonly, the catheter becomes contaminated hematogenously from second bloodstream infection that develops from the other source focus of infection. Bacteria stick to biofilm that is formed and adhere to the internal lumen of the catheter. Then fourth, in rare cases, contaminated infused tent the catheter. That is outbreaks with the contaminated injectable flushes. So this is the pictorial representation of various mechanism of pathogenesis of CRBSI. So as I have explained already, the first one is catheter contaminated inspection at insertion site, mostly extraluminal spray, which caused because of the uh, hospital staff. Then the second route is catheter hub. Third route is catheter contaminated from the secondary infection. And the fourth is contaminated infused. Then the risk factors are immunocompromised host, neutropenia, burns, malnutrition, BMI more than 40, prolonged hospitalization before catheter insertion, and prematurity in infant and limited venous access. Provider factor, emergency catheter insertion, then incomplete adherence to the aseptic technique, multiple manipulation of catheters, low nurse to patient ratio, then failure to remove unnecessarily catheter and device factor. Then catheter material, catheter insertion site, and the indication for use, for example, hemodialysis. Then regarding history, a detailed history with the chronological relevance should be obtained in all cases. Initial symptoms may be subtle in many cases, as some patients with long-term central line use have little immune reserve to mount appropriate response. Thus, in all cases with central line use and suspected infection, CLABSI must be in the list of differential unless proven otherwise and should be investigated throughout. Sometimes it is a patient or nursing staff who notices the initial symptom of local site of infection and inflammation. Specifically in CKD patient, the technical staff may report sudden rise in temperature with rigors and chills and associated hypotension when initiating HD session. Regarding physical examination, a thorough physical examination with check for every indwelling catheter site and its functionality is mandatory. Attempt should be made to visually inspect and palpate centerline insertion site to rule out any palpable cord, expressible exudate, and tenderness. Additionally, one should also look for general signs and symptoms consistent with sepsis. In many cases, the persistent fever is the only symptom of CLAPS. Regarding diagnosis, catheter culture should be performed when catheter is removed for suspected CRBSI, and catheter culture should not be obtained for routine. The qualitative growth culture of catheter tip is not recommended. For central venous catheter, catheter tip should be cultured rather than subcutaneous segment. For culture of anti-infective catheter tip, use inhibitors in the culture medium. Growth of more than 15 colony forming units from 5 cm segment of the catheter tip by semi-quantitative culture, or growth of more than 10 raised to 2 colony forming unit from catheter by quantitative growth culture reflects catheter colonization. When catheter infection is suspected and there is catheter exit site exuded, swab the drainage to collect specimen from culture and gram stain. Short-term catheter, including arterial catheter, and for short-term tip culture, roll plate technique is recommended for routine clinical microbiological analysis. For suspected pulmonary artery catheter infection, culture the introducer tip. For long-term catheter, semi-quantitative growth of less than 15 colony forming unit per plate of same microbe from both insertion site culture and catheter hub culture strongly suggests that catheter is not source of bloodstream infection. If venous access subcutaneous port is removed for suspected CRBSI, send the port to microbiological lab for qualitative culture of the port reservoir content in addition to the catheter tip. Now the diagnosis based on blood culture. Obtain samples for the blood culture prior to the initiation of antibiotic therapy. Where available, phlebotomy team should draw the blood sample. Skin preparation for obtaining percutaneously drawn blood sample should be performed carefully with the use of either alcohol or tincture iodine and alcohol chlorhexidine rather than the povidone iodine, and allow adequate skin contact and drying times to mitigate blood culture contamination. If blood sample is obtained through catheter, clean the catheter hub with either alcohol or tincture of iodine or alcohol chlorhexidine, allowing adequate drying time to mitigate the blood culture contamination. For suspected CRBSI, paired blood culture drawn from the catheter and peripheral vein should be cultured before initiation of antimicrobial therapy, and bottles should be appropriately marked to reflect the site from which sample were drawn. If blood sample cannot be drawn from the peripheral vein, it is recommended that two blood samples should be drawn through different catheter lumen. It is unclear whether blood culture should be drawn through all catheter lumen in such a circumstances. Now, regarding diagnosis of CRBSI, a definitive diagnosis of CRBSI requires that same organism grew from at least one percutaneous blood culture and from culture of the catheter tip. The two blood samples be drawn that when cultured meet CRBSI criteria for quantitative blood culture or differential time to positive. Alternatively, the two quantitative blood culture of samples obtained through two catheter lumen in which colony count for blood sample drawn through one lumen is at least threefold greater than colony count for blood sample obtained from the second lumen should be considered to indicate possible CRBS. In these circumstances, the interpretation of the blood culture that made the DTP criteria is unresolved issue. For DTP, the growth of microbes from the blood sample drawn from the catheter hub is at least 2 hours before the microbial growth is detected in the blood sample obtained from the peripheral vein. This defines the CRBSI. The quantitative blood culture in DTP should be performed before initiating antimicrobial therapy and same volume of the blood per bottle. Evidence is insufficient to recommend that blood culture be routinely performed after discontinuation of antimicrobial therapy for CRBs. Now, general management of catheter-related infection. When denoting the duration of antimicrobial therapy, day 1 is the day when negative blood culture results are obtained. Vancomycin is recommended for empirical therapy in healthcare setting with elevated prevalence of MRSA and for institutions in which preponderance of MRSA isolate have vancomycin minimum inhibitory concentration values 12 mg per ml. Alternative drug is daptox. Linezolid should not be used for empirical therapy. Empirical coverage for the gram-negative bacilli should be based on the local antimicrobial susceptibility data and severity of the infection. For example, fourth generation cephalosporin, carbapenem, beta lactamase inhibitor with or without aminoglycosides. Empirical combination of antimicrobial coverage for MDR, such as Pseudomonas aeruginosa, should be used when CRBSI is suspected in neutropenic patients, severely ill patients with sepsis, and patients known to colonize with such a pathogen. Until culture and susceptibility data are available and de-escalation of antibiotic regimen can be done. In addition to coverage for gram-positive pathogen, empirical therapy for suspected CRBSI involving femoral catheter in critically ill patients should include coverage for gram-negative and candida species. Empirical therapy for suspected catheter-related candidemia should be used for septic patient with any of following risk factors. Like if the patient is on total parenteral nutrition, prolonged use of broad-spectrum antibiotics, hematological malignancy, recipient of bone marrow, solid organ transplant, femoral catheterization, and colonization due to candida species. For empirical treatment of the suspected catheter-related candidemia, use echinocandins and in selected cases fluconazole. Fluconazole can be used for patients without azole exposure in previous 3 months and in healthcare setting where risk of Candida krusei and Candida glabrata infection is very. Antibiotic lock therapy should be used for catheter salvage. However, if antibiotic lock therapy cannot be used in this situation, systemic antibiotic should be administered through colonized catheter. 4 to 6 weeks of antibiotic therapy should be administered to patient with persistent fungemia, bacteremia after catheter removal, occurring once and 2 hours after catheter removal. And for Staphylococcus aureus, to patients who are found to have infective endocarditis, suppurative thrombophlebitis, to pediatric patients with osteomyelitis, 6 to 8 weeks of therapy should be used for treatment of osteomyelitis in adults. Long-term catheter should be removed from patient with CRBSI with any of following conditions like severe sepsis, suppurative thrombophlebitis, endocarditis, blood infection that continues despite 172 hours of antimicrobial therapy to which infective microbes are susceptible, infection due to Staphylococcus aureus, Pseudomonas aeruginosa, fungi, mycobacteria. Short-term catheter should be removed from patient with CRBSI due to gram-negative bacilli, Staphylococcus aureus, enterococci, fungi, and microbacteria. For patients with CRBSI for whom catheter salvage is attempted, additional blood culture should be obtained and catheter should be removed. If blood culture results remain positive when blood samples are obtained 72 hours after initiation of appropriate therapy. For long-term and short-term CRBSI, due to less virulent microbes, are difficult to eradicate, like Bacillus species, Micrococcus species, and Propionobacteria. So catheter should be generally removed after blood culture contamination is ruled out on the basis of multiple positive culture results, with at least one blood culture sample drawn from the peripheral vein. Uncomplicated CRBSI involving long-term catheter due to pathogens other than Staphylococcus aureus, Pseudomonas aeruginosa, Bacillus species, Micrococcus species, Propionibacteria, fungi, or mycobacteria because of the limited access site in many patients who require long-term intravascular access for survival. Treatment should be attempted without catheter removal with use of both systemic and antimicrobial log therapy. After positive culture result is reported that may represent CRBSI, automated standardized treatment advice can be formulated to improve compliance with Infectious Disease Society of America guidelines. Urokinase and other thrombolytic agents are not recommended. If catheterized patient have single positive culture that goes forms, the additional culture of blood sample obtained through suspected catheter or from peripheral vein should be performed before initiation of antimicrobial therapy or catheter removal to be certain that patient has true bloodstream infection and catheter is likely source. So this is the pictorial representation of management of CRBs. Patient with short-term central venous catheter, arterial catheter, and acute febrile illness. Then divide the patient into two categories: those who are mild or moderately ill, and those with the severely ill that is associated with hypotension, signs and symptoms of organ failure. With those who have mild infection, obtain the blood culture 2 sets. One should be peripheral and consider antimicrobial therapy. If no source of fever is identified, remove CVC and arterial catheter, culture the tip and insert at new site or exchange over guide wire or culture insertion site plus hubs where available. If blood cultures are negative and CVC and AC is not cultured, and if fever continues and no other source is found, then remove and culture the CVC and the arterial catheter. If blood culture is negative and the central venous catheter, arterial catheter culture both are negative, then look for the another source of infection. If blood culture is negative and central venous catheter and arterial catheter is more than 15 colony forming units, then and if it is a Staphylococcus aureus infection, treat it for 5 to 7 days. Monitor closely for signs of infection, repeat blood cultures accordingly. If due to other microbes, monitor closely for signs of infection and repeat blood culture accordingly. So if blood culture is positive and CVC and AC is more than 15 colony forming unit by roll plate of more than 10 raised to 2 sonication method, then it is confirmed CRBSI that we will discuss in next slide. If blood culture 2 sets, one is peripheral, then remove CVC, culture tips, insert at new site or exchange over guide wire and initiate appropriate therapy. So short-term central venous catheter or arterial catheter infection, if it is related to the bloodstream, if it is a confirmed CRBSI, then again divided into complicated and uncomplicated. If it is a complicated Then it is associated with suppurative thrombophlebitis, endocarditis, and osteomyelitis. In that case, remove the catheter and treat it with the antibiotic for 4 to 6 weeks. If it is uncomplicated, that means if the fever is resolving within 72 hours, and if the patient has no intravascular hardware and no evidence of endocarditis, suppurative thrombophlebitis, and staphylococcus aureus, is also is also without active malignancy and immunosuppression. If it is a cons, then remove catheter and treat with systemic antibiotic for 5 to 7 days. If catheter is retained, treat with the systemic antibiotic and anti-lock therapy for 10 to 14 days. If it is Staphylococcus aureus, remove catheter and treat with systemic antibiotic for more than 14 days. If it is Enterococcus, remove catheter and treat with systemic antibiotic for 7 to 14 days. If it is a gram-negative bacilli, remove the catheter and treat with systemic antibiotic for 7 to 14 days. If it is candida, then also we have to remove the catheter, treat with appropriate antifungal therapy for 14 days. Now, proven preventive strategies are catheter insertion cart and kit, hand hygiene, maximal sterile barrier precaution, alcoholic chlorhexidine skin antisepsis, selection of subclavian catheter insertion site, chlorhexidine dressing, chlorhexidine bathing, antibiotic, antiseptic impregnated catheters, manual decontamination of catheter hubs and cap before catheter insertion, and antiseptic containing hubs and caps. Thank you.